I'm Elizabeth Hinkson with Nursing Education, and now we're going to talk about suctioning a patient with a tracheostomy. The first thing we're going to look at is equipment. We're going to need a continuous oxygen saturation, so we can watch his oxygen saturation throughout the procedure. And then we're going to need a modified embu bag. Notice that my modified embu bag is stored in a protective cover. It's going to come to you from respiratory therapy, and it is good for about 72 hours. So as we said, this is primarily just an embu bag with a plastic adapter and an inline suction device attached to the end. This will allow us to oxygenate and suction and treat it as a clean procedure instead of a sterile procedure. You might remember the old kits that you opened up. There were sterile gloves and all of that. This allows us to treat it as a clean procedure with just clean gloves because the suction catheter remains inside a protective sleeve. The only time the suction catheter comes out of its protective sleeve is when it is in the trach. So it's either in the sleeve or in the trach. It's never out in the environment, so we can treat it as a clean procedure. Now, in order to suction, we must consider that first we're going to pre-oxygenate. We're going to be vacuuming out all the air in our patient's lungs. So before we do that, we want to pre-oxygenate. It's the standard of care. For an embu bag, we'll have it up to 15 liters. We'll see, like always, that our reservoir bag will inflate. We also will need some suction. It is recommended that your suction dial on your suction gauge should read about 150. Our suction just attaches right there. Now you notice on your inline suction that suction is engaged when you push the button. There's a safety made on these so that now that I twisted it, it's locked in place. I can't push it down. So if you come upon a suction device that doesn't push, just twist it around so that it does. Now it's engaged. Now I have all my equipment set up. I'm on 100%. I have my suction attached. So we have our continuous monitor. But in order to suction a patient, we have to have done a respiratory assessment so that we determined a reason to suction our person. If we look at this person, we can see that their oxygen saturation is 88%. That can be a reason to suction. Sometimes a patient's respiratory rate will be increased. We'll see their work of breathing increased. We listen to their lung sounds and we can hear secretions. There's a lot of secretions laying around the tracheostomy. Our patient is signaling to us that they feel like they need suctioned. So look at your respiratory assessment. Are there things that you could potentially improve with suctioning? Then you have a reason to suction. So I've determined based on my SAT, and suppose my person is coughing, that he would benefit from suctioning. So here we go, Mr. Bill, we're going to suction you. I take my non-dominant hand on the trach. I attach my modified embu bag. Now I'm supporting both the trach and the suction device with my non-dominant hand. This is important because if we jiggle around the trach like this, it is uncomfortable for our patient, and it also can lead to swelling and bleeding at the stoma site. So we always support to minimize movement. My dominant hand now is going to come over here and I'm going to pre-oxygenate. But my person has their own respiratory effort. So I'm going to watch for their chest rise, and that's when I'm going to squeeze my bag. So where he sees chest rise and I squeeze. You'll notice that we're squeezing about 1/3 to 1/2. And again, with the patient. Pre-oxygenation when suctioning is a standard of care. Hopefully, if we raise their SAT close to about 100% as we can, we'll avoid a vasovagal response when we suction the air out of their lungs. It also increases their tidal volume and mobilizes the secretions we're trying to suction out of there. And thirdly is really just for patient comfort. So we'll do this for about 60 seconds to 2 minutes. In a real patient, we'll watch their SAT raise, close to 100 as we can, and then we're ready to suction. Again, my non-dominant hand has not moved. I grab my suction catheter and I slide it down, holding onto the sleeve on the outside. Now I'm going to slide it down on a real patient, right where the two main bronchi break off the trachea. As I slide out of the plastic trach, I'm going to trigger a cough motion or a gag motion in a patient. That's when I stop advancing. I'm going to pull back about 1/2 inch or a couple of centimeters. I'm going to engage my suction and this nice slow, smooth pull out. That's it. The only thing we're suctioning is the hard plastic of the trach, not the actual airway. Then I'm right back to oxygenation. I'm replacing all the oxygen that I just suctioned out of there, again matching with their respiratory rate, right? And while I do this, I'm also reassessing my patient. I'm determining if that was adequate or if I need a second pass. So what was my problem that made me decide to suction this patient in the first place? Was it an increased respiratory rate? Was it a low SAT? Was it a bunch of secretions? Was it the way their lungs sounded? So I'm going to have a look at my patient to determine if I've fixed that or if I need a second pass. If I need a second pass, it looks the same as the first. I advance, advance, advance until I see the cough motion. I stop. I pull back a couple of centimeters. I apply my suction, nice smooth pull back. And I'm back to post-oxygenation and reassessment. Now, if you find that whatever your problem is in your respiratory assessment that led you to suction, and you aren't able to resolve that after 3 passes, you're going to want to consult with whoever your respiratory therapist is and think about what is really going on with our patient. So after we're done, I disconnect. Again, my suction catheter is safely in its sleeve. I'm turning off my oxygen and my suction. I'm going to take my bag and I'm going to put it back into its protective cover so that I am ready for the next time. Thank you for watching, and if you have any questions while you're caring for a patient with a tracheostomy, consult with your respiratory therapist.